For example, I interest whether kidney transplant subject who had hepatitis B antigen positive, recipient who perform kidney transplantation, whether they have hepatitis B antigen, surface antigen positive or not, and the outcome is graft failure. You see that this exposure and the outcome is quite need like a large time to follow up. So if I just perform like a prospective study, it might not enough subject or power to detect the outcome. Baseline on this exposure, whether they have hepatitis B or not, and the outcome whether they have graft failure or not. I on this time now, for example, if I be in 2015, but I also enrolled 10 years back of the subject. Remember that dynamic cohort study. Even I let the time 10 years back, but every subject did not come in the same time, right? They come consecutively. Depends on the date of operation, because our defining of the cohort is that start from date of operation for kidney transplantation. So that's why we have cohort of kidney transplantation and they identify at baseline whether they have hepatitis B or not. That's our exposure. During the time, even I look back here, the number is just 200 cases. So I still use this definition, new case, because I cannot stop here because the subject is not enough. So I still allow this eligible criteria that new kidney transplantation, even they be transplant in the future. And in 2016, 2017, 18, I will include in the study and look whether they develop kidney graft failure or not. And also the one who already operate from 2010, for example, I still follow up them. I still follow up. So you can see that because it's a follow-up time, it's not just like this arrow here back. When once you identify subject from this, it means that you still follow them until the end of study. But in this design, the end of study is not present. The end of study in the future, still be in the future. So you can get some subject might have 20-year follow-up here. So that's the good point that you have quite long-term follow-up enough to answer about this question. Okay? Okay. We talk about the outcome measurement, right? Whether the outcome assessed equally and can be keep it blind or not. So focusing on outcome measurements, you might see many words of them. First, they might categorize as subjective outcome. For example, develop fever, develop pain, they have good quality of life, well-being, for example. That is subjective. So it depends on who make the adjudication, or depends on who judges whether this is pain or not pain, right? Sometimes it's a questionnaire for the subject to report whether what they feel, what they grading about the pains or the quality of life. So if it depends on the subject like this, so the way you measure and also the blinding is very important because it might influence systematically for the reporting of the subject outcome that we call bias, right? Because they are aware about the group, so they bias to report you about the pain score, about the fever score, for example. And another one is you might categorize as subjective or objective. The objective means you can measure it by like a rigid criteria, not depends on feeling or reporting by people. For example, hemoculture. You use the criteria to count how many colonies that means positive for hemoculture. You might use the staining of the fluorescent staining. How many grade of stainings mean positive for fluorescent staining, for example, or death. Death is always objective. No one have equivocal death or not death, right? Because you can see. But right now, just have the meeting. If you did not concern much in detail with the brain death, it is circulatory death, so it's still okay. But if you like a very detailed man, it's still objective. If you consider whether it's brain death or not, okay. So I ยอมแพ้อยู่นะคะ But if it's death is mostly it's not subjective. Okay. Another things or another system to categorize outcome is whether it's surrogate outcome or clinical outcome. Surprisingly, that I asked this question with our medical student. They know the word surrogate. I asked, why you know that? Oh, I saw the movie. And they saw some movie about surrogate. Movie named Surrogate. Okay, so they can explain very well about surrogate. Surrogate means that this is like a biomarker outcome that is come before the clinical outcome. So you need not to wait for a long time for their changing. For example, low density lipoprotein or LDL we use to be the surrogate of cardiovascular death, or proteinuria we use for the surrogate of end-stage renal disease, for example. So these ones is come before the clinical outcome. Mostly right now you might familiar with the word biomarker, still surrogate, right? But biomarkers might be both surrogate or mediators. Another word that now coming hot right now for the field of epidemiology is the word mediators. Mediators, you can measure it as surrogate, and it was the mediator to cause the clinical outcome. For example, proteinuria here. If you can identify the mechanism that proteinuria can cause end-stage renal disease, it's not just the surrogate to measure the outcome, but by itself, it can cause tubular injury. So that's why we have interstitial nephritis. So that's why we have end-stage renal disease, for example. So that's why you can identify the mechanism of this. So proteinuria might be both surrogate and also be mediator. Another example, like if you can identify that periodontitis is associated with diabetes, and also diabetes associated with coronary heart disease. So now diabetes act as mediators for periodontitis to cause cardiovascular disease, or periodontitis itself might cause cardiovascular disease, but all by mediators or by itself. So this is more complex of association. So right now, in field of epidemiology, we complex in analysis more and more because we trying to use what we understand in the medical view to be tested in statistics. Because some disease, some cause is not direct cause from these factors, but it might be indirect passed by some mediators. Okay.
When we use surrogate or mediator.
If we use the word surrogate outcome, it means like it's just another outcome. It's just like the outcome, but it's come before the clinical outcome. but it's outcome, so it doesn't mean that it causes the clinical outcome. For example, if you think that LDL itself, if you cannot claim about the mechanism or the effect of LDL directly to death, so you just think that it's linked to death, but it's not cause death after. So that's why they think this is surrogate. But if you do sure that LDL, it had some effect directly by itself from LDL to the death, so that's why you might consider it as mediators. But right now, I think mediators still the new word or new terms. I just explained to you. Otherwise, when you read the article, sometimes you might see mediator analysis. It seems like this. But in the past, we think this is just surrogate. So surrogate means
I wonder the leader can
how can we choose which one is surrogate, which one is mediator, right?
At that time,
So
someone
it depends on the background of the mechanism. Whether right now you know well about this surrogate or not, whether how can it be associated or how can it work, or what's the mechanism that of pathophysiology involved with this surrogate. For example, the most obvious example, like you interest in BMD, bone mineral density, right? Exposure might be smoking associated with BMD. And actually we want to know about the fracture, bone fracture, right? But BMD, we can measure it before. We can measure it from nuclear medicine to measure it before. But in this case, BMD is not, I don't know how to explain. BMD, how can it cause fracture afterward? Because itself is not the cause for anything, or it do have any pathophysiology to cause fracture. But it's not like proteinuria. If direct hypertension, 2 millimeter per lot increase proteinuria, and proteinuria itself, now we claim we have the study in animal that high proteinuria, it causes tubular damage, and it causes tubular interstitial more than no proteinuria. So that, and we can have animal study to show that direct proteinuria cause tubular injury. So that's why you can have some link here that it cause the effect to be here. So that you might think this is a mediator. But for BMD, I think nowadays we still think that it's still the outcome, but it's not have any physiology to explain how BMD will do fracture in the future. This is an example.
now is proteinuria is both surrogate or mediator.
Yes. If you have like an animal study support you, or in basic like a translational method, they can, BMD actually they have some, but it's another way to measure, like for BMD you get the point, right? But if you have some biomarker, like you measure TNF beta, for example, and sometimes in the past we think like a surrogate, but right now it can act by itself, so it might be like a mediator. Mediator is a part of clinical outcome. Mediator is a part of clinical outcome, but sometimes we think it's that surrogate, but it acts as mediators. Okay, I think we already answered when should we use cohort design. Everybody in the room know first when we conduct risk study, second, observational study, or third, even you interest in intervention, but interest in the term of effectiveness, you can conduct cohort study as well. Okay. Actually, we can do both, all of the question. We can make it in diagnosis study too. And I think we already understand about this, right? Risks mean that we have at risk to develop the disease. And after disease develop, what is the factors to predict other clinical outcome? So it seems like in the spectrum of disease, you focus on the risk factors to develop acute MI here. And after MI, you want to know who will be dead after that. Sometimes risk factors like a male is a risk, male's higher risk to develop MI than women. But after MI occur, female more likely to die, for example. So it might not need to be the same factors. Cohort can be used in many purposes. For example, if they interest in exposure, so we assess risk factors like lung cancer in people who smoke. This is exposure, this is the outcome. If you focus on disease, so it's like you focus on the prognosis of that disease. Survival rate for the patients who already had breast cancer, right? This is still the cohort study, whether how many years to die or the median time to die. Or you might interest in preventive intervention, like to assess the prevention effects, reduction in the incidence of pneumonia after pneumococcal vaccination. So this is the intervention, vaccination. And you look whether who received vaccination, not received vaccination, and then how many cases develop the incidence of pneumonia after that, after follow-up. Or if the character is a therapeutic intervention, you focus on the effect of treatment. So like the improvement in survival for the patient with Hodgkin's disease who given chemotherapy. Even the question is look like therapeutics or treatment, but you can do in cohort study also, because this is a real world effectiveness of this chemotherapy, right? And then we move to the second part, how to assess the risk or association. The risk is the probability of some unexpected or unwanted event. The probability that people who are exposed to certain risk factors or some characters will subsequently develop the disease. So the risk means that like if we have some characters that might be the risk, then and how many probability or how much of a probability to develop the disease after we follow up for the time. And for measurement the risk, we measure it as incidence, right? We measure it as incidence because we know that we have subject who observe, and then the new case that develop after that will be the incidence of that characters or that factors. But the problem is, this is a problem, really problem in real life. One exposure, for example, high blood pressure, it can be the risk of congestive heart failure. But it also causes another disease also, right? High blood pressure also be the risk of other like coronary arteriosclerosis stroke, renal failure, or MI also. And also, in other hand, you can see that among one disease, right? If you focus on congestive heart failure, it can be associated with others, many risk factors also, like dyslipidemia, positive family history, valvular heart disease, viral infection, smoking, and DM. So that's why multiple causes and effects makes us hard to claim about the causal relationship or the association, right? Because mostly cohort study we used to claim the causal effect or association, but in reality it's hard because it looks like not just one exposure cause one disease. This is multifactorial to cause them. So that's why we talk about many advanced technique in statistics to try to claim about causal relationship, because it's not just straightforward one by one. In the past, we just think like, okay, we have this dichotomous outcome, yes or no, and we have these factors, and then we adjust for other confounding factors. That's it, it's finished. But right now, no, it's not easy like that. Still have chance to competing whether this exposure, why don't they have other outcome, and other outcome might competing this outcome also, for example. So that's why life is difficult more and more when we learn more and more, we know more and more. That's right. For my thesis, I analyze is really easy because on that time, 10 years ago, just adjust for confounding factors is okay. But now your turn is not. I good that I but before you, okay?
For the congestive heart failure, it means just the condition that have to several
event.
Yes, just only event. It means in my mind it's not equal with the DM or valvular disease or viral infection. Mm-hmm. In the clinician, it's very concerned.
You think that it seems like DM
yes.
is also the condition, right?
Yes, yes.
So for the risks, mostly we think about the possibility of an event. So that event might be like this, like a condition. We don't use the word disease. It's not the probability of disease, you remember? They did not state like a risk is the probability to develop the disease. No, it's just a probability to develop event. Event is very broad word. Anything can be event, right? Okay, that's the first point. The second point, the Ajahn raised that, okay, DMU also health condition or health event. Why don't you think like this? Because I think if you focus for one event, it's impossible that it might have another event that relate with this. But the way we think or the way we calculate, in this example, hypertension, whether it's a risk of congestive heart failure or not, and then you have to consider other risks of congestive heart failure. Also diabetes, also dyslipidemia also. But the way you calculate, you have to focus for one event to be the dependent variable. And remember that you have to think that this risk factor or exposure or event before should come before this one, because this is the scheme of cohort study. But if you say that I don't know because everything happened together all the time, so you cannot claim the causal of them. But in this case, it means that at first we did not have this congestive heart failure in the cohort study, but we have this health event whatever what you want to call, or risk factor. We have all of this at the beginning, but not this. But after follow-up, these events occur or happen. We just want to assess what is the risk for this, and we focusing this is our interested exposure. So that's why we have to adjust for this confounding factor. Okay, but if you do cross-sectional study, everything happen on the same time. It's hard to clarify who comes first. So that's why you need cohort to follow up. I think we already talked about this one, right? The way to express and compare risk. Absolute risk. The question is, what is the incidence? Incidence mean risk again, okay? In the group that initially free of the condition or event. So I incident here is a new case, number of new case, divided by the total number in the group that we interest. Attributable risk or risk difference. The question is, what is the incidence of disease attributable to exposure? So you have two incidence among exposure minus incidence in non-exposure. And when we talk about relative risk or risk ratio, it asks about how many times that more likely exposed person become disease relative to non-exposed person. So this is formula. And also population attributable risk. What is the incidence of disease in the population associated with the prevalence of risk factors? So this is the formula. Population attributable risk equal attributable risk, this one, multiplied by prevalence of what? Exposure. Very good. Okay. And this just show you how to calculate. And I think any question from this? Dr. Yan, do you have any question? Are you familiar with this one? We are repeating medicine, repeating 3 times already right now. Okay, so make sure that it insert to your brainstem already. Okay, so it's the final one to get out from your brain. Okay. We talk much about relative risk and attributable risk. Relative risk show us strengths of association. The more number of relative risk show the higher strengths of association. We don't have clearly cut point in epidemiology. Mostly more than 2, I think is very influence factor right now, because think about in general population. If any risk factor can cause 2 times more, it's significant in epidemiology. But if you have more than that, it should be better. But remember that every time you see the point estimate, you have to look at the 95% confidence interval every time, okay? We use relative risk to causal inference, and is valuable in etiologic study. For attributable risk or risk difference, right? Because it's incidence exposure minus incident non-exposure, is measure how much the disease risk is attributable. Attributable mean like a มันมาจากอันนี้มันเกิดจากอันนี้เป็นภาษาไทยนะคะ is attributable to a certain this exposure. So it valuable in clinical practice because in clinical practice we can calculate number needed to treat or number needed to harm from AR, and also it valuable in public health because we can use in assessment of impact. Remember the word impact last time, okay? This one. This is population attributable risk. if we have effective prevention program that can remove, in this case, exposure to kidney stone from the population, how much a reduction in chronic kidney disease outcome incident could be anticipated or expected in total population. So this is the number that kidney stone attribute to chronic kidney disease in population. So if you have program to prevent kidney stone, so we will decrease the incidence in the population around this number. So incidence rates is, go back to measurement again, is the measurement of disease, which is the proportion of subjects who develop disease under study within a specific time period. So the numerator is the number of disease subjects. The denominator is a person year of observation of patient at risk. Okay, so we now move to servo analysis. If you look at the dynamic cohort here, you can see that subject might come to your study. It's not in the same time, right? And if you can count or cumulative the total person year of observation, in this time is person month, not person year, sorry, because the unit here is month. The total observed time is 69.1 months, and D mean date, W mean withdrawal, and stop like this is lost to follow up. Okay, and the end of study is over there, around 10 months after follow up. So this is nature of study. Someone might come not in the same time, someone might lost to follow up, someone might withdraw, deny to enroll in the study, and A means still alive until the end of study. So that's why you can think that it's might hard to count the number at the beginning, because subject is not the same time at the beginning. That's why we mostly use servo analysis in cohort study, because it's hard to find fit cohort. Mostly we deal with the dynamic cohort. So servo analysis is an analysis that can be done in cohort or randomized control trial. Even randomized control trial, if you have experience in that, you did not randomize them in the same day, right? It depends on subject enrolled in your study. So the way they enroll is not on the same day. So you cannot start with the 1st of January to be randomization. It's impossible to do that. So it looks like dynamic cohort also. Okay, so the servo analysis is the likelihood that patients with a given condition will experience an outcome at any point of the time. So it's a time to event analysis from the origin. So you have to set the origin to the outcome, and the end point here is the end point of study. And also, if the patient develop the outcome before the endpoint time, we also classify it as endpoint also. Why we need servo analysis? Because investigators mostly must analyze data before all subjects have been dying or all subject has occurred, and do not typically the patient did not enter study in the same time as I just mentioned. And when we do analysis, imagine that we have the date of end of study, right? If at the end of studies we will consider whether the event that we interest occur or not. For example, in this case, if you think that the event is dead, so the code dead equal 1. 0 mean censored or not occur. Censored here mean either alive or lost to follow-up or withdrawal. Only dead that the interest will be counted as 1. If you read the dictionary, epidemiologic dictionary, whether censored, what does it mean? คนไทยเรียก censor. Censored mean that the observation that we don't know the outcome. Why we said the unknown outcome? Because on that time that we observe, they did not develop our event. But after that, we don't know, right? During the time of follow-up here, the first subject did not develop dead, that is our outcome. And she withdraw on the 5th month. But after this, we don't know what happened to her. So we guarantee only the time that we have observed that during this follow-up, she did not have outcome. So we categorize this subject 0 censor, but the time of at least is only 3.5 months, for example. You get the point? So we just guarantee that during this time they did not have outcome. After that, don't know, censor. หยุดการ follow up เพียงแต่แค่นี้ okay? And also like this subject, the subject. This is not withdraw, it's lost to follow up. We don't know again, but under the during 3.5 month follow up, this subject did not have disease. So that's why we still count as censored. But for this subject who developed dead, it means that during 7 months of follow-up, they developed dead. Now it's 1. The code is 1 because it's not censored. So it depends on your interest. For this example, I just show you one outcome. That is our interest. But sometimes you might consider with the composite outcome. Death or hospitalization, for example. Death or stroke, for example. Death or stroke is our composite endpoint. So if go back to this scheme, if this subject develop stroke, the code will be 1 also. And the time to follow up still 3.5. So depends on whether what you want to consider as your outcome. You might use a single event or you might use combined event we call composite outcome. Just one event that occur, we will count as 1. Are you confusing with this? No? Okay. I think I have another example, but after that we talk more. Otherwise, I think you might confuse. Okay. So beginning is like this. So methodology of characteristic of survival study, you have to have 3 components, very important to in methodology in order to create survival analysis. The first one, you have to have the starting date for each patient, whether which definition that you use to clarify this is starting point, this is the origin. For example, maybe the date of diagnosis, maybe the date of receiving treatment in case of prognosis study, or might be the date of operation. If you remember this, it looks like the starting point of cohort, right? Because you're trying to find some character that permanently defined in your subject, so that you identify the cohort. You use the date to be the starting point of your cohort. Okay. And the second part is the end date of each patient. So that means that you have to identify what is the duration for each subject. If they're still alive until your study date ending here, so the duration is a total time here, right? If they withdraw before, you just count them only during the follow-up. If they die, it's a time to origin to their death. Okay, so each patient have to have their own date of both origin and then the end. And the third part is what is the status of each subject on that end date. This patient on that end date, she is dead. This patient on that end date, she is censored. This patient, she censored, for example. You have to clarify one by one whether each subject have status in which category. So, patient status at the end might be dead or alive, recurrence or disease-free, infections or non-infections, remission or non-remission, or complete remission, partial remission, depends on your definition. Recovery or non-recovery. Sometimes it might not just binary outcome, yes or no. It might be 3 outcomes can be possible. Depends on your defining of the patient status at the end. And then you can calculate the survival probability of people that have such a range of time that you've given them and estimate the survival function. Now we call survival function. It's reciprocal with hazard function. When we talk with survival function, we talk about the good side, the percentage of survive, and another hand is that the hazard function. So it's reciprocal together. If we talk about survival functions, is it high? So it means that hazard function is low. Okay. So choose the way you presentation. And again, in the command in your software, it depends on what you want to show. Whether you want to show hazard function or you want to show survival function, but it's combined together is equal 1. Okay. So survival function is the estimate of proportion of individuals who survive longer than time t. Remember why we said longer than time t? Because we just had time of observation over there. That's that time t, right? After that, we don't know, but we know that still alive on that time t, over than that. Okay. It's equal number of individuals who survive longer than time t divided by total number of the individuals. Actually, we have many methods to calculate the survival analysis, and basically the first one is life table analysis. You can do it by hand calculator. In the past, we have to calculate by ourselves, like a standardized mortality rate. But right now, we almost always use Kaplan-Meier probabilities. And next slide, next issue. So I just show you here the way the things, but need not to concern about I have to do this or not. No, you don't have to do it by yourself, but you have to understand the concept. because life table is a basic concept of survival analysis, then we develop to be Kaplan-Meier probability. Okay, what they do is that the basic that during the follow-up time, we have to categorize or grouping the interval time to be start from 0 to 3, 6 months and 9 months. Like you create the interval time of follow-up. And then during each interval, you have to think about NI is the number of subjects entering this interval. Start with 13 subjects. And WI is the number withdrawal during the interval. Withdrawal might be withdrawal, might be lost to follow-up, might be dead. Everything's mean withdrawals, okay? And number of the terminal events here is mean dead because the event that we interest is dead. And we calculate the proportion of terminations. Is equal QI is equal DI here, number of terminal events, divided by the sum of NI minus WI minus 2 because we think about interval. So they divided by 2 because it's like an average. Okay. And PI here is the proportion of surviving. This is a survival probability. And is equal 1 minus QI here because it's the proportion of terminating. And then summarize proportion survival at each interval. So that's the concept. Okay. For example, first interval, they enter 13 subjects, withdraw 2, dead 1. So then you calculate QI equals 0.083. So then the observable proportion probability here is 1 minus this number, 0.917. The cumulative here is equal because it's just first interval. Next interval, 0 to 3 months. During 3 months, because start with 13, right? Withdraw 2, terminate 1, so you left 10 subjects enter here. 10 subjects enter here, withdraw 4, terminate 1, dead 1. So this is the proportion of dead here. So NI 10 here minus WI 4 divided by 2, and this is DI equals 0.125. So then again, PI for this interval is 0.875 because this is PI equal 1 minus this number. But right now, you got the second interval, right? So the cumulative probability here is equal this number multiplied by this number. This number multiplied by this number, so it's equal this. Okay. So the concept of that life table analysis used to be the new concept that is Kaplan-Meier method. Kaplan-Meier method is different in mostly the obvious differences is they did not use the interval to count who come in out, who come in next. No, they did not use the interval to count the number. They use the real event. So they use the time that event occurred. Compare with this one. This one fix the interval and count the event, how many withdraw, how many dead. But this one, because they have event, so they will calculate survival probability on that time. For example, the first event here occurred at 3 months because they have a dead here. And the second one occurred in 4 months. You see, it's not interval because we have censored here. The third event occur in 5.7 because another censored subject. And the fourth event occurs 6.5 because now we have event also. So the number of event time here is not regular. It depends on real happening of the event and also censored. The dynamic change, every time that have dynamic change, they will calculate the serval probability. That's the first thing that the concept is different. And they also have NI, but right now it's not number for entering, it's number at risk. Okay, and censored, how many censored, how many number of events, the mortality, and survival, and cumulative survival. So you follow this, you can observe that if you have events that you interest, for example, death, the survival will be decreased. But if you see the second row, you just have censored. You don't have any effect on cumulative incidence, cumulative probability. But it shows you the calculate on this event time. But the cumulative still the same, 0.9, 0.9, because these are censored too. Not affect with the cumulative survival. Just only the number of events will affect the survival. So when you draw the survival curve, you will see like this. Like this. This is the same example. Only the events occur, you will see the step down of the curve. If you have only censored, no effect on the cumulative survival probability. These two guys censored, so they just show you censored, but not effect on survival probability. And this time, 5.7 years, right? Okay, 5, 6, 5. We have another 6.5 years. We have another 2 dead. So that's why survival probability going down again. So just only event that we interest occur, you will see the lower of the survival probability. We have only censored. They did not have effect to the survival probability. So this is the Kaplan-Meier probability. In this example, you will see that at the start time, I mean the time follow-up 0 month, everybody have one of the survival probability or 100% of survival probability, because at start everyone alive, no outcome. And during the time of follow-up, the survival probability decreased by the time of event rate. And when you draw the line 0.5 of survival probability, so what does it mean here? It's a median time, right? So this is what we want from Kaplan-Meier survival curve estimation. We want to know what's the median time of this interested group, and we can compare together. If this subgroup have median time 10 months and another group have median time 12 months, 2 months apart, it means that the intervention gives the benefit 2 months of median time, and we can calculate whether it's significant or not significant in terms of statistics. Anyone confusing about this? No? Okay. So right now, when you learn about survival analysis, mostly Ajahn will teach you in Kaplan-Meier survival estimation. So that modified from life table analysis. And like I told you that hazard function is another cumulative hazard function is another one that is reciprocal to survival function because it's proportion or probability that individual will die after time t. For survival function, individual will survive after time t. So it's reciprocal. Okay. How to comparing between the two curves of Kaplan-Meier? Mostly, it's just you have to know that servo analysis or Kaplan-Meier is not normal distribution. It's non-parametric method. Okay, because it had to be normal distribution for the death rate of subject. Also, probability is not the normal distribution. It's always skill based. Okay, skill mean based นะครับ based เอียง based นะครับ so how to compare it so we use log length test the word is non-parametric method right length when you see the trick is when you see length some sign length test some test length if you have length it means it's not normal distribution right it is non-parametric method and the null hypothesis to comparing is that you might use the null hypothesis of servo t equals servo 2 equals servo probability 3 or you might use hazard 1 equal hazard function 2 equal hazard function 2 or you might use the median time 1 equal median time 2 the same meaning just which one what you choose you choose servo probability or servo function or you use hazard function or you might use median time okay it can reflect the servo function also and the log length statistics you use the O is observed number event E is expect event in group okay I will not go on this I think it's my but if you look at this it looks like a chi-square if you learn you learn about chi-square already in physics that quite class don't have to learn งงสายหน้า okay mostly when you see this it means that you have the real event that is observed event and you calculate the expected event so the point is how to calculate expected event because real event or observed event you can get it from your real cohort right so the way to calculate E here is that so you have to have time that have event dynamic here right and these mean the number of death N's mean number at risk so right now you have group 1 and group 2 because you want to compare between two curve two group 1 and group 2 here and you combine together this mean group J again อีกแล้วอะไรก็ชอบ combine together like we create standard population when we talk about direct method standardization right so dj here equal 15 plus 15 here and sorry nj here equal 15 plus 15 here this is 30 dj is a date the cumulative date between group 1 and group 2 so it's equal 1 because no date in group 2 just in group 1 so use this population to calculate the expected it's the same like you calculate standardized okay so E1j equal N1 just the number of 1 dj and nj so N1 here dj is 1 right N1 is 15 divided by 30 is equal 0.5 for the first row I think it's the same because just only one subject right but for the second one you might see the difference because right now you see that number at risk you change because in group 1, because you have dead, so number at risk reduced to be 14. But group 2, you don't have dead, so the number still be 50. So that's why when you calculate them all and sum together, we will get the different number. So this is a total expected event in group 1. And these are the total event in group 2. If you have time, you try to calculate, you will understand as I try to talk to you. And yes, you have the observed number, right? Because it's a real death in this group 1 and this 3 death in group 2. So you can calculate the chi-square here right now. It's a log length test, and you get the chi-square number here. You can see the statistic p-value here. 0.01 is mean that the death rate here observed is over than expected, because we expect only 4.9, but they did 10. So these numbers mean that group 1 did more than group 2. The solvable probability is lower than group 2. Is it statistical significant? Because observed is over than expected probability. And also, that's just log length test. Another thing that you can calculate from survival analysis is the hazard ratio, HR, hazard ratio. So in this time, you calculate the observed 1 divided by expected 1 and divided by observed 2 divided by expected 2 from that number. You can get hazard ratio 5.5 here. Does it mean? It means that the risk of graft failure at any time in discipline older than 50. Graft failure is the outcome. Discipline older than 50 is the risk factors. Is 5.5 times greater than the risk in discipline with non-exposure. Sometimes some epidemiologists argue that you don't use greater. You should not use greater word in hazard ratio. You should have faster, because it's time to, right? It's time to event. So older will have 5.5 times faster to graft failure than younger. That should be the right word. If you see some very strict epidemiologists, they will argue you every time you use a term greater in hazard ratio, because you should use faster or quicker. Okay, so this is the format that you will familiar more and more in Stata, right? In Stata, you will familiar more and more with the command here. You have to write down. You should not wrong any even parenthesis or even command. You should not wrong, because they did not accept any wrong command in Stata. Okay, and this is the output from this command. That outcome is graft failure, exposure is the age group, and you can see that mostly they report time at risk. Time at risk means person time, right? Person time denominator, and this is the total subject. This is the time at risk. Total subject is 253, but time at risk is 831 year, person year. Okay, and the incident rate is 0.08 per person year. And they will show you the survival probability, 25%, 50%, and 75% survival probability. So if you have time at 50% survival probability, what does it mean? This is the median time. So this format, you get the median time if your data have reached or touched the 50% line of survival probability. You see that only the group that younger that have the median time here, but the group older than 50 did not have. It means that the survival curve is not reached the 50% of survival probability. So you have to familiar with this format because you have to look the data from this, and you can calculate the log length test by expected event and observed. Remember, expected and observed that we have to calculate by themselves, but right now we just use the command st-test to calculate for you. You will get the chi-square here and probability. So it's not significant here. Don't confuse with my example here. It's just example, so it's not the real data. This is the real one, real data. So you see that in this case mean that exposure age group is not associated with graph failure because the chi-square here show non-significant p over 0.05. Okay. So now we already learn about Kaplan-Meier log length test. We used to compare the survival curve. It's just the observed expected calculation, right? Log length test, I show you the formula. And also Cox regression to determine the factors of survival time. What means Cox regression? If you learn about the regression analysis, it means like the regression analysis อะไรคะอาจารย์ regression analysis is like the formula เป็นสมการ so it's an equation, right? But depends on what you consider the type of variable. If your variable, I mean dependent variable, is continuous number, you will analyze it as the regression analysis. But if your dependent variable is dichotomous, sometimes dichotomous you might use logistic regression analysis. But in this case, your dependent variable is time to event. So you use Cox proportional regression analysis. So it depends on the dependent variable that you interest from the design. ผ่านดีกว่าถ้าทางจะไม่ไหวแล้ว Okay. Okay, don't worry, we talk it again in prognosis study. Okay. Today, just let you know about person time, median time, log length test, and median 50% of survival probabilities is enough for you, I think. I show you here an example, and actually I want to go through the subject number 3, so I have to lap very quickly. So the paper is about the different impact of hepatitis B virus and hepatitis C on the outcome of kidney transplantation. And the method is the cohort of consecutive end-stage renal disease who underwent first kidney transplantation and 6-year follow-up. Conduct in Raama Hospital. This is an bidirectional cohort study because we go back to 1997 and then follow up until 2006. So that's what Ajahn Sawarak asked us. It means that from the eligible criteria subject who had enrolled our study, we still follow up them until the end of 2006. Okay. Study population inclusion criteria is our medical record of adult population who do the kidney transplantation, exclude multi-organ, and the exposure that we interest is hepatitis B infection hepatitis C infection or non-hepatitis B or C infection. And after classify this subject at baseline of enrollment, I mean at the origin, subject will follow up whether they have graft failure or not. The primary outcome were time to graft failure, and graft failure were defined by the dialysis. And this is the statistical analysis we just already talked all of them. So if you look at this, you have two sets of covariable. The first one is the baseline data, right? That should not change over time. So we call time fixed covariate. Like gender should not change or maybe change. Transsexual, okay. So สตรีข้ามเพศ Have you ever heard that? ดร.ยันงง okay. So gender, sex should not be changed, right? Age at transplant should not be changed, right? Like diabetes, previous history of diabetes should not be changed. So this is called time fixed covariate. Everything that should be fixed during the baseline. But it still have another set of data that might be changed over time. That we call time-dependent covariate. For example, the level of the drug change over time. The level of blood pressure is not fixed number. The level of LDL cholesterol, for example, the dose of the drug is not the same. So if you not conduct the prospective cohort study, it's hard to do this. But we can do ambidirectional in our center because all of the data of this covariable will record in our questionnaire in the case record form. But if you do the retrospective study or ambidirectional study that you did not have any background about this database before, so it's hard to do because you need like a follow-up data that even may change over time also. So that's why you have to plan if you want to do the good cohort study. And this is the result. Now you understand the graph right now, right? The graph here come from Kaplan-Meier probability. And every time that you see this, remember that this is a unique variate analysis. Otherwise, they have to specify under the graph that this is adjusted already or not. If they not specify under the graph, it means that it's come from unique variate analysis. The exposure is a group of hepatitis profile. Whether the blue one is non-infected, the red one is hepatitis B infected, the green one is hepatitis C infected. So all subjects were categorized by exposure like this. So this is just one variable, but they have three categories. Are you confusing? No? Good. So just one variable of exposure, but they have three categorized. And outcome just one also. That's graft survival. Graft failure, yes or no. So that's why I call this is unique variate analysis. Okay? And the log length test show p-value significant. And another analysis in the same population. Now we move to patient death is the outcome. When I talk like this, remember that, okay, it means that the panel on the left hand side, I use event as graft failure, right? Graft failure mean 1. Loss to follow-up mean 0. Withdrawal mean 0. Alive until 7 years mean 0. What about death? What about death in graft panel on the left hand side? If death it's not my interest in the left hand side because I focus on graft failure. So that should be 0, right? So on the left hand side, that is 0, is censored. So another word that we call is a graft survival probability, that censored. If we spell like this, it's clear. It means that I focus only graft failure. If that, just censored because I just kidney doctor want to look at only kidney whether it's work or not. But on the right hand side, I say that the outcome of interest is death. So event death equal 1. Withdrawal 0. Loss to follow-up 0. Alive 0. Graft failure but alive still 0, right? Because graft failure is not my interesting on the right hand side, but graft failure but dead, we still use the dead on that date. Are you confusing? Are you understand what I talk? Okay, good. So that's why the left hand side sometimes we call dead censored graft survival, and the right one mostly we did not call graft failure censored because death is come after graft failure also. So you need not to concern much if you focus on death, right? Right? Because death is a final one outcome. And sometimes you might combine the result, right? If you want to do analyze again, the third analysis, the outcome death or graft failure. So right now, you combine outcome this together. So the curve, the probability will change. It's not be the left, it's not be the right because it's combined together. So on that case, one mean either death or graft failure. We will code it as 1. Are you confusing? Very good. Okay. So now we also analyze the hazard ratio from this, right? And you can interpret this like this. For example, like a hepatitis C positive subject will have 3.8 times faster to develop graft failure compared to hepatitis C negative subject with p value 0.001. Okay. Okay. Potential bias in cohort study, selection bias, measurement bias, and survival cohort and confounders. I think for selection bias or susceptibility bias is mean that if you look in the whole group of cohorts, but sometimes in your group they might contain some subgroup that not equal in the susceptibility to have disease that you interest. For example, if you consider about CA level and the relapse rate of the CA column, but in subject with CA level, it might have some factors that take it more risk, like a Duke classification. It might involve with the relapse too. So it is possible that the distribution of Duke classification is hard to do. Oh, sorry. Okay. For example, okay, like when you interest in some factors, but the underlying in baseline factors sometimes, if like you want to interest in smoking and lung cancer, but you know that if patient exposed to some toxin also have chance to be the lung cancer also, but the distribution of the toxin levels might not equal in the same group. Or another example, like if you know that smoking can cause CA lung, but men and women might not the same risk. Women and men are more easier. Okay, so women have higher chance to develop lung cancer more than men. So if the distribution of the proportion of gender is not distributed equal between smoking and non-smoking, so you might not comfort to conclude about the smoking status and outcome. So the way you can do, you might be subgroup analysis to reduce the selection bias of the group, or you might do matching, or you might do adjusting in the analysis. So the way to control for the susceptibility bias, because every subject might not have the same susceptibility bias. We have method for controlling. The first way, the best way is randomization, but remember that randomization cannot be done in risk study. So this way, so we discuss them in this topic. But this is the way to control selection bias. And we use in the design, not in the analysis. The second one is restrictive. I mean that if you worry about gender might interfere the susceptibility bias. So that's why in your study, you restrict only men in your study. You did not include women in your study. You use restriction. So restriction means you cut down your sample size. Just only the group that you sure that should not interfere with susceptibility. But it's not good for the most epidemiologists because you lost some subject a lot, right? You lost subject because you restrict them. But you can use in the design if you have a huge number of population, so you might design like this. The third way is matching. Matching means that you might use some scoring, or you might use some character to match between exposed and non-exposed together. For example, if you can match, you worry about gender, right? So exposed smoking, non-exposed smoking. Sorry, exposed smoking is exposed, non-smoking is non-exposed. If your case smoke is male, so you choose non-smoking male also. If your next case you have exposed is female, so you match with the non-smoker with female also. This is called matching of the exposed and non-exposed group to reduce susceptibility bias. It's also in the design tool. Another thing that we use in matching, I did not answer you yet today, but if you do read this assignment, they use the propensity score for matching. Propensity score, I explained to you here that is the way of matching also, but they use score to be matched. For example, if you know that treatment A, drawing my better, okay. You know that treatment A, you have treatment A and treatment B, right? For me, if the subject will treat with drug A and drug B is conventional, and I may be idea. For TB treat, pulmonary tuberculosis treatment, this is a standard one, and this is a new agent for pulmonary tuberculosis. But you did not do the randomization because it just look at the effectiveness in the population, and you look at your data across the country, whether how many cases that they were used with standard regimen, how many cases used with the new regimen, and you will see that all baseline characteristic between this one drug A and drug B, age, sex, severity, blah blah blah, DM for example, is different all, right? Because it's by practice, it's more likely that new treatment give in a younger, for example, and more likely to be female, more likely to be less severity, for example, more likely to no DM. So everything is based like characteristic different, p-value less than 0.05 all. So it make you that it might have susceptibility bias, right? Because subject receive A and B is not equal because we cannot do randomization. But we try to match them by the hypothesis that why they receive A and B. So you calculate the probability or chance to receive drug A. Even your first PICO is here. PICO, you pulmonary TB subject, drug A and drug B, and the outcome is complete remission, complete อะไรนะใช้คำว่าอะไรนะเขียว ฉันก็จะ remission อย่างเดียวเลยโอเคเขียว okay so actually our PICO is whether pulmonary TB subject drug A and drug B and the cure rate. But the first time that you trying to reduce this susceptibility bias is that you calculate the chance to receive drug A. So your outcome first is whether why they receive drug A. So you calculate, you create the equation or the regression analysis in order to find the factor, these factors, whether which one associate with drug A prescription. So that's the first step of propensity score matching. Do analysis, whether why they receive A here. So you get, okay, age younger, sex female, severity high, no DM for example. So you got this characteristic and then you weight by the scoring. Now you can create the logistic regression to determine who received A, and then you can get the beta coefficient from that scoring system. And then you create the score. So then every subject, go back to my cohort again. Go back to my cohort. You can get that ID number 1 from this scoring system. How many scores that he have? For example, if the total score is 10, for example, they got score 5 because they're older but not female, for example. You got the score here and create the score. For each subject, you will have the score. Then you use this score in adjusting analysis, or even you use this score to match the subject. I mean, a subject should have score. For the first subject, they receive A and they have score 5. So you have to match subject B with score 5 also. So after matching here, the total subject enrolled in the study will be reduced. But what you can get now, when you do analysis based like characteristic again, you will see that this is comparable. Because you fit it because you matching already. Matching by what? Matching by propensity score that you already created. So propensity score is the way to match the data, and you can do it if you have enough sample size. You have very little number. For example, 200, 300 don't talk about probability score matching. You should have more than 5,000 subjects. It's just kidding. I mean 1,000 to 1,000 subjects. Because after matching, your sample size will be reduced a lot in order to make it comparable. So you have to reduce your sample size. So make sure that you have enough cohort to be matching. Okay. The fourth one is stratification. Stratification means subgroup analysis. So you do subgroup analysis among male and subgroup analysis among female and look whether it has confounding factors or not. It have different outcome or not. Or you do like in adjustment in multivariate analysis. This is use the statistic to be adjusted. Okay. In this design, you might have someone drop out. You might have someone turn from non-infection to be infection after follow-up. This is crossover. So sometimes you might use another one we call best case, worst case analysis. It means that you suppose suppose that all of dropout are graft failure. That is worst case analysis. Or you might suppose all of dropout are alive, no graft failure. So that is a worst case analysis. This is another method to deal with try to analyze in susceptibility and bias that might occur. But I said that mostly we prefer only this is enough. I never see best case, worst case for a long time, so you just know the word. But mostly they did not use it right now because we have another way, like a propensity score match, for example, more advanced than worst case, best case. It's like a big guess. Just guess that all of them are graft failure or all of them are no graft failure. So it's not work right now. So measurement bias. So if patients in one subgroup of cohort have the better chance to have outcome detected than another subgroup. So it's not good because it creates the ascertainment bias or measurement bias. So the way to control this bias, you have to make the person who record the outcome unaware of the outcome, set up the strict criteria, the rules of diagnosis the outcome, and apply effort to discover outcome events equally between groups. And the final one is the survivor bias. So because we're tracking participants over time, so it might lost between, for example, if the true cohort is like this, we have subject 150 and we can follow up all of them until the end of study, and we see that the outcome improve 70%. So the observed improvement and true improvement is the same because we can follow up all of them. But survival cohorts mean that we have 150, but we have a lot of number non-observed because we cannot find their medical record. It's out of our banking already. It was no available right now for the medical record of 100. So we just have only the one who actually follow up, walk to the OPD to follow up with us, 50%. Actually, in that time frame of cohort, we should have 150, but we have only 50 that still follow up with us. But the left 100, we cannot retrieve them at all. So if you look at only the one who can follow up with you, you see, oh, they improve a lot, improve 40 in 50. So the observed improvement is 80%. But if you can identify all of them that did not follow up with you, you might see that they might not improve 65 and improve only 35. So when you combine together, actually the true improvement is 50%. But because of the follow-up or the solo cohort make you have over-interpret your treatment effect, that improvement is very good. We saw a lot in the real life OPD case, right? If you plan to do study, for example, my question, if I want to study this one, but I don't use the real cohort from the origin, so I just look at my OPD case and look at the actual follow-up subjects and whether how many cases that perform kidney transplant during the time, the same period as my study, but just the one who active follow-up in my OPD case. And I look for the association between hepatitis B and graft failure. I might see a very, very little association because many of subjects might die before or left on or refer to another hospital, right? So the lesson from this is that you have to identify the real inception cohort. So not just the OPD case that you have look at every day here, because you might suffering from survival cohort, because the one that still follow up with you doesn't mean it's a real cohort, right? You see the difference between two examples? The first sample, I mean that you have to have the list of subjects that fit with your criteria at the beginning and follow up them all. Not just use the case in your OPD case, because you might don't know that what's left behind you, right? They did not come to see you, but they did not have the good outcome as this. And the final one is confounding factor. So I think it's not explained again. So feeder to look for the cohort study, how much selection bias was present, were only patients at risk of outcome include, was the exposure clear, specified and measurable, were the exposed and unexposed groups similar in all important. This asks for susceptibility bias, right? Okay. And what steps were taken to minimize information bias? Was the outcome clear, specific, and measurable? Was the outcome identified in the same way? Was determinant of outcome made by the observer blind to this treatment? It's hard, but some good cohort they do. How complete was the follow-up of both groups? What efforts were made to limit loss to follow-up? Was loss to follow-up similar in both groups? Why? Because we want to know that how many percent of follow-up should be less, especially less than event of interest, and at least they should similar rate between loss to follow-up between group exposed and non-exposed. Were potential confounding factors sought and controlled for in the analysis? Did investigator anticipate, think before, and gather information on the potential confounding factors? What methods used to control for confounding factor? So we have many methods, right? Both in the design and also in the analysis to control confounding method. Okay. So in conclusion, cohort study, if you've done well, it can generate similar result as RCT, and some questions that cannot be answered by RCT, cohort can do. And you can see the strength and weakness of cohort study and what you have to concern. Mostly is on the selection of population, mostly is based on how to measure exposure and outcome, can you blind it, and also how to control confounding factors. That is very important. Okay, just brief look. If you have in hand the study of effective of long-acting reversible contraception. This is the study published in New England Journal 2012. Anyone read it before? Okay, I think you might read it before, and we met again in causality. Right? Am I remember right? I think so. So just read it, and we might use around 15 minutes discuss it before we go through the causality. Actually, it's very good example for causality also. I think this paper. So we might discuss in that class is still okay. But I did not want to discuss before you read it. Okay. And for your assignment, I think it's very interesting fact. It's not interesting journal, and you can see, when if you clearly and carefully read in them their methods, might see something. Okay. Don't worry much that someone asks that, oh, Ajahn, I have to answer a lot ยาวๆ like a long essay to get the good score. It's not like that because the keyword is not long. Keyword is not long, but it's not too short. When I say like this, someone answer to sentence, it's too short. So try to explain as what you understand. I want to know what you understand or not. But it's no need to copy the paragraph to explain to me. To just explain, no need to copy the page or the paragraph for me. Okay.